All right. Good morning, everyone. Thank you so much for joining us. We were very excited to bring Dr. Berman across the country out of her 26-degree weather into our gorgeous 68-degree Phoenix day. But alas, the snowstorm had other plans. So she's joining us remotely from the East Coast. But regardless of logistics and location, I am delighted to introduce you to a caring and compassionate pediatric surgeon who is leading the charge in surgeon well-being. Dr. Lauren Berman is a professor of surgery and pediatrics at the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia. And she is a pediatric surgeon at Nemours Children's Hospital in Wilmington, Delaware. She serves as the Director of Surgical Quality and Safety, the Surgical Director of the NICU, the Patient Safety Officer at Nemours Children's Hospital. She is also the Program Director for the Pediatric Surgery Fellowship and the Pediatric Surgery Research Quality and Safety Fellowship. Dr. Berman is currently the Chair of the American Pediatric Surgical Association Wellness Committee and the Director of the National APSA Peer Support Program. Additionally, she helped to found the Nemours Children's Health Enterprise Peer Support Program and serves as a member of the steering committee. Today, she will be presenting Supporting Recovery After Adverse Events, a critical component of surgeon well-being. Thank you and welcome, Dr. Berman.
Thank you so much, Dr. Garvey, for that introduction. And I'm really sad that I can't be there in person. I don't think I've actually ever given this talk virtually, and it's a kind of a tough one to give virtually. So hopefully we can connect, even though I'm not there in person, and have some meaningful discussion now, at the end of this hour, and then I think a little bit later this morning. I'm really looking forward to that. So Dr. Garvey introduced me really generously, and I have no conflicts of interest. When I do these grand rounds, I go on the website of the place that I'm visiting. A couple of these are from your website, but what I find on all the websites, I think really depicts the positive side of what we do as surgeons and as healthcare providers taking care of children. What we do is so incredibly rewarding. I feel lucky every day that I get to have a career that gives me such fulfillment. To take kids when they're at their sickest, to take families when they're at their most vulnerable and to be able to interact with them and help them through those times and usually with great outcomes. But I always say, the highs are high, but the lows are really low. So when you think about, this side of the coin of what we do, it's hard to reconcile that with the fact that, suicide is much more common in healthcare professionals than it is in the general population. And I think there's a lot more attention being given to this now than there used to be, certainly when I was in training, and people are starting to talk about it and try to think about it and understand why. And I think we're making a lot of progress, but there's still a lot of progress to be made. Every year, the equivalent of a full medical school class of physicians commits suicide. So this is a topic that's a little tough to talk about, and I'd like to intersperse some photos of where I live in the nicer times of year. I love running. That's sort of one of my major outlets to kind of process difficult events and just kind of my meditation in general. This is a little running path nearby, and I have a few more pictures like this spliced in. And I just wanted to kind of talk a little bit about my personal journey and how I got involved in this. Because, listening to Dr. Garvey say I'm leading the charge, when I hear that, I'm like, who, me? Like, I know I still don't really think of myself that way. And I have to confess, earlier in my career, I was sort of like, I won't say a well-being doubter, but I was sort of like, well, if you're burned out, like maybe you just need a different job, right? This isn't for you if you're burned out. What we do is amazing. And if you're not experiencing that and enjoying that, you're the problem. And I had a really kind of altering personal events that made me really change my mindset on this. And I'm sure some of you in the audience right now might sort of be thinking the way I used to think. And my hope is maybe I'll change your mind today. But I was about 4 or 5 years into practice, and I was on call, and A 2-year-old was hit by a car, run over, and came in awake, alert, with vital signs. We were resuscitating in the trauma bay, getting access. And then, I mean, many of you who take care of children know they seem totally fine until they're not. They're really able to compensate, and then they just kind of fall off that cliff. And that's what happened. So we ended up having to take him to the OR. And he had a completely crushed liver where he had been hit by the car. And he died on the table after a lot of efforts to save him. So then I had to go and tell this family whose child had come in, awake and talking, that he hadn't survived. And it was um it was horrible. I kept thinking, like, was there something I could have done to save him? If someone else had been on call that night, would the outcome have been different? I was terrified every time I was on call, that something like that was going to happen again. I didn't talk about this with anyone. I talked about it a lot at M&M, at trauma care, case review, trauma peer review, all these conferences we have when these significant events happen. But I didn't really talk to anyone about how it was making me feel. Um, and months went by, and my husband was the one who pointed out, like, you are not yourself, like, you're not okay. And I was just like, I'll be fine, I'll be fine. And I couldn't think that I could actually be a pediatric surgeon and have those feelings, and that those two things were compatible. And I couldn't even let myself experience or talk about those feelings because I felt like that would mean I'd have to, like, find a whole new line of work, and I just wasn't cut out for this, and I couldn't face that. Um, and then I went to the AAP meeting in the surgical section, and Kurt Heist, he's a now retired pediatric surgeon. He worked at Showa in Atlanta, and he, for his chairman's address at the surgical section, talked about something called second victim syndrome. And it was exactly what I was experiencing. And I'm going to talk more about that this morning. But just hearing that and learning about it just was absolutely life altering for me, because it made me realize that there wasn't something wrong with me, and this was actually quite normal, and it's actually described and studied. And so I think in that moment, I really pivoted and committed to, like, helping other people learn about this and normalizing it. So that's what I really hope to accomplish today with you. I want to define second victim syndrome, how it contributes to burnout, um, and then talk about peer support as something that can actually help us recover in a productive way after a significant adverse event. And then I know there are a lot of efforts ongoing with you at Phoenix Children's to build your own program. And so I will talk about our experience building our program at Nemours. And I really want you to think about peer support, even outside of, the concept of a formal program, as a vehicle for culture change. Um, so those are our objectives today. So I mentioned there's been a lot more attention to the concept of burnout and the argument. There's a business case for investing in well-being. If a physician leaves your organization, it costs double that physician's salary to replace that physician, and there's a significant loss in productivity. So it makes sense for organizations to invest. More importantly, when people leave, we lose our colleagues, and we miss them personally and professionally. And I think that's really the real argument here. Burnout among surgeons was described back in 2001, quite a long time ago now, by Daryl Campbell in this publication. And they characterized it as emotional exhaustion and depersonalization. And these are scales. You can take surveys, and these can be measured. And what they did was measure the relationship between burnout, emotional exhaustion, and depersonalization and medical errors, and found that if you have committed a medical error, you're much more likely to experience burnout. And then if you experience burnout, you're much more likely to commit a medical error. So it's this vicious cycle that perpetuates itself if we don't, address it and confront it, which our culture really discourages us from doing. So there's a patient safety argument here too. Just in terms of the scope and the scale of this was a huge survey of physicians in the United States and Canada. 90% of them in the survey said they had committed a medical error, and greater than 90% said they felt there was no support from the institution in the wake of the error. We also know that committing a medical error correlates with suicidal ideation, more than double the rate of if you have committed an error, you're more than twice as likely to experience suicidal ideation. So this was the original publication, also from early 2000s, the year 2000, that described the concept of second victim. And I remember reading this, and it just rang so true to me. And I remember experiences during training, during being an attending, where this happens. And I think this will all sound familiar to you. When I was a house officer, another resident failed to identify the EKG signs of tamponade that would rush the patient to the operating room late that night. The news spread rapidly. The case tried repeatedly before an incredulous jury of peers who returned a summary judgment of incompetence. I was dismayed by the lack of sympathy and wondered secretly if I could have made the same mistake and, like the hapless resident, become the second victim of the error. So I think we've all experienced this phenomenon where something goes wrong and then you think that, well, I could have done the same thing. And the definition of a second victim is a healthcare provider involved in an unanticipated adverse patient occurrence who experiences psychological and emotional trauma related to the event. So this isn't just about medical errors. This can just be an unanticipated negative outcome. Even if you didn't do anything wrong, it can be just as jarring. These are the feelings that second victims experience. I won't read through all of them, but I think many of them, like, they were part of the story that I told of that 2-year-old trauma patient. Um, and if you read through them, I think probably many of you have experienced this as well. So when we convened the APSA Wellness Task Force, um, we did a survey just to kind of look among the population of pediatric surgeons, APSA members, how common it was to commit a medical error that resulted in patient harm or death. And similarly, we found that, almost 80% of us had done that, and many, within the recent past. And we also asked questions about how satisfied were you with how your institution supported you in the wake of the error, and only about a quarter of people said that they were satisfied. These numbers are actually much better than that large US and Canada physician survey, but still pretty alarming, I would say. So not everyone experiences second victim syndrome. It's possible that, one of my partners could have been on call that night and had the same outcome with that child and not been as destroyed by it as I was. Um, this has been studied, and we know that surgeons, anesthesiologists, OB-GYN, and pediatric providers are at higher risk. We know that females are at higher risk, trainees. And if there is a case that involves a medical error, an unexpected adverse outcome, if it's the first death that you have experienced as a provider, or if you have a special connection with the family. So I think many of you in this room fit into one or more of these categories. I think as pediatric healthcare providers and as proceduralists, we take things especially hard. I think when we do something with our own hands or fail to do something with our own hands, it somehow feels a lot more intense, I think, than if you, forgot to prescribe a medication, or I think it's just especially personal. And I think we really tie it into our view of our competency and our skill level as surgeons. Um, I wanted to say a little bit about the gender findings. And this is depressing, and I don't really have a great solution, but I think this shows that the struggle is real. This was a study looking at referrals to surgeons, and it found that after a patient death, the referrals to female surgeons dropped by about a third. Whereas for male surgeons, if one of their patients died, there was like a small stagnation, but then it recovered. So I do think the female surgeons are judged more harshly, and that perhaps contributes to the more common occurrence of second victim in females. So I wanted to just kind of share some quotes from the survey that we did of the APSA membership. And this is just when we asked the questions, we asked sort of why, or describe more about why you answered that way. And this was about the question about like why you didn't feel supported by your institution after the adverse event. Doesn't matter where you work, if the error is big enough, you're thrown under the bus and nobody wants to get on that bus with you. There's no discussion or education, just blame and punishment. People came to M&M with pitchforks. We are going to talk a little bit more about M&M later. And then this is a common thing. Colleagues are well-meaning, but they just don't know what to say, or they just don't say anything at all because of the sensitive topic. And this really gets at the role of peer support, um, which we will get more into. Um, this concept of repeated trauma came out in our survey, and this comes out again in the trajectory of second victim syndrome. It's really kind of enduring the Inquisition. The error was reviewed at three separate M&Ms at two different institutions. I had to write a description of it 2 times. References followed for 6 months. It was repeated mental trauma. And I feel this probably sounds familiar to many of you. And the peer review process is very accusatory. It places us in defensive position and exacerbates the guilt that already exists. There was a strong message that came through in these open-ended comments that people feel that the hospital prioritizes its own interests above the clinicians. Um, there's a mistrust because of the risk management conflict of interest. The approach was an exercise in face saving and finding a scapegoat on part of the administration, and the institution prioritizes itself, not surgeon well-being. And these are just illustrative quotes, but these themes came across consistently in these open-ended comments. So I mentioned the trajectory. Susan Scott is a nurse, scientist, PhD, who has studied second victim syndrome, has interviewed many people who have experienced second victim syndrome and has kind of identified these stages of recovery. The chaos accident response that happens right in the wake of the event, the intrusive reflections where you can't stop thinking about it. You try to restore personal integrity, but then you're enduring the Inquisition, which I mentioned before, which is all these repeated M&Ms and kind of case reviews that you have to get through. You hopefully obtain emotional first aid. And then the last stage is moving on, and there are 3 different trajectories that you can take when you move on. Um, the most common is surviving, and I think that's what I was doing. I was sort of going to work. I seemed fine on the surface. People close to me, like my husband, could tell that I just wasn't myself, but I was like putting on a really good front because we're really good at doing that as surgeons. Um, so I think that's the most common thing that happens. Thriving is really the optimal goal, and we're going to talk more about that. And then the really scary thing that can happen is dropping out, and people might leave medicine altogether or worse. So this is the trajectory that's been described. And now I want to kind of start and make the case for peer support. This is another one of my running paths near my house. So there's been some studies. Jo Shapiro, I highlighted her name above. She's an incredible leader in this field. She has helped dozens, probably more, of institutions establish peer support programs. She helped us establish our APSA peer support program. And she was part of the study where they interviewed physicians after a medical error, and there were 8 themes detected about what helps recovery. And many of these themes are things that will come out during peer support. Also, this study showed that physicians want support from physicians. We don't want to necessarily talk to someone from employee health. We don't want to talk to, mental health professional. We want to talk to people who have been in our shoes and who can relate to what we're dealing with. And we asked about this in the survey. Who would you want to be contacted by after an adverse event? And we worded it that way. We didn't say who would you want to talk to. We worded it as like, who would you want to reach out to you? Because surgeons will not reach out for help. You need to reach out to them. And only 11% of us said that we would not want to be contacted by anyone. So the vast majority do want to talk about it. And then most of them said that they would want to talk to their partners or other physician colleagues. And there was some interest we threw out there. This was before we built the peer support program. There was some interest in the institutional peer support. Oh, sorry, this was institutional peer support program. We also asked about an APSA peer support program. So I think surgeons do want this. And then this was one quote that I thought said it really well. Having personally experienced a patient death, I think a peer support program in which members are given training in how to support the traumatized physician would be the optimal choice. Colleagues are well-meaning but don't know what to say or don't say anything at all. The chaplain can be helpful but can't truly understand because they don't have the same responsibility to a patient. And that's sort of the case for peer support. So my argument to you is that peer support can really help us, and when we get to the stage 6, moving on, move into the thriving rather than just going into survival mode. And this is just some quotes illustrating the point that we do want someone to reach out to us. I appreciate that they took the time to have someone reach out. It made me feel less alone. I was contacted in the afternoon and told my next day was canceled. I met with the support person who guided me through the process of recovery, and I can't tell you how much I appreciated it. It made care for the next kid that much better. So I think one of my big take-home points for today is just to reach out to your colleagues when something bad happens. And these are the common myths that we think about. He wants some time to process everything, and he's feeling isolated and alone. Um, you may be thinking we should lessen our caseload, and then that's interpreted as that they've lost confidence in my abilities and they don't trust me. You may think I don't know what to say, and they think I wish everyone would treat me normally. Um, you may say, well, I don't want to bring it up because I don't want to make her relive the situation. But meanwhile, she's thinking about this constantly. So you bringing it up isn't going to make her think about it more. And I think when we experience a significant adverse event or an error with a bad outcome, you start to see yourself through this keyhole. You start to forget about all of the really incredible things that you bring to the table, and you just let the error or the death define you. And that's definitely what's happening to me. And I think peer support can really help us bring us away from that keyhole and think about our whole selves. Um, so I'm going to do like a little miniature version of peer support training. This is not complete, but I really want everyone in the room right now to have some skill set that they're leaving this lecture with, to be able to take to their colleagues. Um, so this is sort of what peer support is and what it is not. Sometimes when I talk about this, I start talking about peer support and they're like, well, what does that even mean? So I want to just explain a little bit. This is hard for us as surgeons. It's witnessing and sitting with suffering and tolerating others' distress. We are fixers. We want to fix the problem. We want to make people feel better. And that's not what this is about. This is just about being there with them and letting them feel their feelings. Um, it's not therapy, it's not counseling. It's not correcting the facts about the past events or getting into the nitty-gritty case details. It's very much about being in the present. It's talking about how the person is coping with the event. It's exploring feelings and reactions. It's not jumping to conclusions or trying to like know how they're thinking. And so normalizing the reactions and the feelings and the thoughts that they're having and not trying to just cheer them up and reassure them. It's meeting them where they are and respecting their reactions and beliefs and not imposing your own beliefs. And it's helping the person identify their needs and connecting them to resources. And it's not about like telling them what to do or giving them advice or solving their problems. So I'm going to play this little clip. This is from the movie Inside Out, the first one. And as you're watching the clip, I want you to be thinking about, so here's joy and here's sadness, and something traumatic happens to, I think his name is Bongo, the elephant, and I want you to think about who's being the better peer supporter, and you can type it in the chat or yell it out, but I'll let you play this.
Wait, Granny, that was me. Still has some salt power left. Congratulations, Granny. Granny can't be done with me.
Hey, it's gonna be okay. We can fix this. We just need to get back to headquarters. Which way to the train station?
I've had a whole trip planned for us.
Hey, who's ticklish, huh? Here comes the tickle monster.
I'm sorry they took your rocket. They took something that you loved. It's gone. Forever.
Sadness. Don't make him feel worse.
Sorry.
It's all I had left of Riley.
I bet you and Riley had great adventures.
Oh, they were wonderful. Once we flew back in time, we had breakfast twice that day.
Sadness.
That sounds amazing. I bet Riley liked it.
Oh, she did. We were best friends.
Yeah, it's sad.
Okay, now. Come on. The train station is this way.
All right. So I don't know if I can actually see the chat, but Um, watching this video, actually, when we were developing our Nemours peer support training, really taught me a lot. I think I tend, even a little bit into my peer support journey, I tended to be a lot more like Joy. And so I really do think a lot about the sadness character and try to embody that in these encounters because I think it's really hard for those of us who tend to have a very positive, optimistic outlook and like to fix problems to just like let people feel the way they're feeling and not try to distract them or talk them out of it. So I think that's a really good thing to think about when you're doing peer support. Um, you know, you can kind of see all the different examples of what I just said. When we let them experience their feelings and don't try to talk them out of it, we're communicating that this is normal and it's okay and appropriate to feel sad versus like, you're making me uncomfortable. Can you just please get over this? Or making them feel like it's wrong to feel that way. So when we do our peer support training, we separate it into 4 stages, and I'm going to just briefly go through each stage. Um, the introduction can sometimes be the hardest part because it's getting over that hump of like feeling awkward or feeling like they don't want to talk about it or you're going to make them think about it even though they're not already. And the way I'll broach the conversation is just like, hey, I heard you had a tough day in the OR today. How are you doing? Just say it. If it's this kind of informal partner to partner support. If it's a formal reach out through the program, we do provide training on how to introduce yourself. And then the exploration is really just like the listening. You don't even have to say a lot sometimes. You just like let them talk and kind of name their feelings and restate what they said, and that makes them feel heard and really focus more on how they're doing, not really the details of what happened necessarily. I will get back to that because I think as surgeons, sometimes we need to and want to talk about the details, and sometimes that's what's helpful to be talking to a peer because they can engage at that detailed level. So just put a pin in that. But in general, it's not supposed to be sort of like a drill down of like play by play what happened in the OR. So with exploration, we talk about open-ended questions like how and what and tell me about this. Don't ask why did you do that or why do you feel this? The why is a kind of a more judgmental term to use in a question, and just encourage the answers. Like I said, just sometimes being quiet and letting them keep talking. Tell me how this has been impacting you. What is it like to be at work when you're feeling this way? What is it like to be at home? Normalizing, I think, is really important. This may be where it's appropriate to connect their experience to something similar that you've experienced, really reassuring them that this is a very normal reaction, and that there are phases of recovery. I think for me, I was constantly thinking about this. I couldn't sleep. I remember being on like long car rides where I spent the entire car ride just thinking about it constantly, reliving it, fearing that it'll happen again. And that's all very normal. It doesn't feel normal when you're going through it. This is from that same huge study about the impacts of medical errors. And you can see how common these both physical and psychosocial symptoms are: fatigue, sleep disturbance, rapid heart rate, increased blood pressure. So this is all very normal. And I think just emphasizing that in these conversations. And then also, this is when you are supporting someone that you know and that you work with, affirming them. When you say like the same thing could have happened to me, or actually the same thing did happen to me, that can make people feel so much better. And just to say, I have confidence in you and I trust you. And this is not in a way that you're just trying to cheer them up or talk them out of it, but just to kind of affirm them. I think this is something that we are in a special position to do when we are providing support to the people we work with every day. And then the follow-up. So like, are you sleeping? Are you eating? Exploring whether they need to take some time off. What have you done when something like this has happened to you before? What has helped you recover? Make a plan to check in. I usually say like I'll check in with you again in a couple of days. And even if they don't want to talk about it the first time, I'll still say, all right, that's fine. I'll check in a couple of days. And then knowing what the resources are in your local environment that you could connect them to if you need to. Assessing their coping resources. Is there anyone else you can talk to, or do you have a support person at home? I wanted to say a word about malpractice. So this gets into when we were talking about like the details of the case. So when we do our peer support training, we intentionally direct people not to talk about the details of the case. And actually, we say if someone starts to get into the details, you should steer them away from that and talk more about how are you feeling. I strongly disagree with that as a surgeon. I think it feels really hard when a person really needs to and wants to talk about the details, and then you try to distract them or move them in a different direction. The truth is, when you have a peer support encounter, that is not a protected encounter. You are not a healthcare provider for that person. And so theoretically, if there was a malpractice suit related to the case that you're providing peer support about, you could be deposed. And I think it's important to know that. I think the reality is that, you're not taking notes during these encounters. If you were deposed, you would not be able to provide much that would be useful. And Joe Shapiro talks about this in her training, and to her knowledge, to my knowledge, it has never actually happened that someone has been deposed in a malpractice suit as a peer supporter. And I think the fact that it theoretically could happen should not be a barrier. And I think that's a really important point. I also think that sometimes you can go through an event like this and then the lawsuit comes months or even years later, and then you get put right back into it. And we at Nemours are actually we actually have a program to provide peer support specifically for physicians who are facing litigation. So I think it's really important. And I don't think this should be a barrier at all. I'm happy to answer questions about that if people have them. So this is a more in-depth guide to becoming a peer supporter. There's a lot of the content that I just shared, but it's more in-depth. We had built out this kind of virtual training platform for the APSA program during COVID, when we were having virtual meetings and having things called APSisodes. And these are really a great resource if you want to kind of learn more and get more into it. If you watch all three of these, I think it comprises a pretty complete training. The only thing you would add to that is during a role play practice session, because I think it's important to actually practice the skills, and that's what we do in our trainings that we continue to do for the APSA program. And I think these also, a really cool feature of these is Ed Barksdale was the president of APSA at the time we rolled out the peer support program, and he gives a little personal story introduction, and there's one from Steve Stilianos and Marge Arca as well. And I think their insights are the introduction to each of these episodes, and I would really encourage you to watch if you're interested. And then this is a video. Hopefully these slides will be available to all of you. I'm not going to play it now because we don't have time, but it's a full soup to nuts peer support encounter that Kurt Heiss is practicing with one of his partners. And I think it's really helpful to just watch it from start to end and kind of get a more sense of what it should be all about. I mentioned knowing how to access support. So familiarizing yourself with your local resources, peer support program, employee assistant program. And Dr. Garvey was actually able to get me this slide in case any of you are not aware of these resources. There's an employee assistant program that there are 8 free confidential sessions per year. If you want them, there's a wellness program, and there's this email contact and lots of ongoing activities. And I know that there are efforts underway to build a peer support program. So it seems like there's some pretty great comprehensive resources. So how to start a program. I'm going to tell you the story of Nemours. I don't know how familiar you are with our healthcare system, so I'll just kind of share. We are the largest children's healthcare system in the country, care for about 250,000 children annually. And we have a Delaware Valley location, which is where I practice, which is our main kind of the mothership. And then in Florida, there are 2 other freestanding in Florida, there's 2 hospitals, and then the one in Delaware, about 8,000 employees across the system. And I like this slide because where we are now and where we started, I never thought we would get here. So just taking tiny little steps to start can lead you to your goal. And what I call the first phase of this kind of the grassroots efforts, this was after I heard Kurt Heiss's talk at the AAP, and I came back to my institution and I was really wanting to explore starting a program. So what did I do? I just kind of got on every meeting agenda that I could, with thinking about trainees, thinking about who's educating the trainees, thinking about clinical leaders, focusing on the high acuity zones where there's a lot of maybe adverse outcomes, the emergency room, the ICU, the operating room, and just presenting about second victim syndrome. I learned about it, I knew about it, it changed things for me, and I wanted other people to know about it too. I did a grand rounds, I presented at kind of the leadership meetings, division meetings, etc., just to kind of increase awareness. And then we had a wellness retreat for our fellows. I'm the program director for a pediatric surgery fellowship, and there's about like 60 fellows of different types at Nemours Children's Hospital. And we were putting together a wellness retreat. And so we decided to do a session about second victim syndrome and educate the fellows. And also, we didn't really intend, we did one of those, um, surveys that you do through the slides, and we unintentionally gathered data that actually ended up being very powerful in advocating for the need for this at our institution. Um, and I put this quote up about vulnerability because everybody knows the surgeons in the hospital, and I think people would see me in the hospital and they would never think that I had a story like the one I told you. And I shared that story with all of the fellows, and I think that was a powerful message to them just to kind of normalize it and start the conversation and being willing to be vulnerable. So during the session, this was what we did. It was a poll everywhere, I think. Have you ever experienced second victim syndrome? After we defined it for them, over half of them said yes. And these were not just surgical fellows. These were everyone from, general academic peds to the allergy, immunology, to anesthesia, to surgery, et cetera. We asked open-ended questions about like what would stop you from asking for help, and the common answers you can see being judged, feeling shame, feeling like there's a critical environment, not sure who to ask for help. We had a few people who actually said that their mentor wouldn't be able to help them. We asked, how often have you been concerned that a colleague may be experiencing second victim syndrome? And this was even higher. The vast majority said once, twice, or even 3 or more times. And then what would stop you from reaching out to a colleague? This sounds familiar too. They're not sure what to say. They're not sure how to ask. They might embarrass them or make them feel judged. So I think this really demonstrated how common this was among our trainees and how ill-equipped we were to kind of support them. So it was a call to action. We presented these data to all the program directors and other faculty, and we educated them about second victim syndrome, and we started to build infrastructure to support our trainees. And then moving on from grassroots, this was really pure serendipity. We were working very informally in the Delaware Valley, mainly focused on GME. And then COVID-19 hit, and the organization became aware that we call them associates, the Nemours employees were really suffering and were lonely and were kind of needing support. So that kind of brought this to the level of the enterprise leadership's attention. I had already met with our CMO. I had started to kind of build the case for it, but I wasn't getting a lot of traction. And then COVID really was the catalyst that we needed. And this is where I put a bunch of questions that I think would be especially helpful for an institution like you who's thinking about starting this, figuring out what already exists at your institution. It turned out Nemours actually had a peer support program buried somewhere on their website, and there was actually an active email, peersupport@nemours.org, but nobody was actually monitoring it. And there was really someone had started it years back with like good intentions, and it just sort of fell to the wayside. But just like figuring out what already exists and how do you integrate into that. Where does a peer support program sit? Is it within EAP? We have a chief wellness officer, so we were able to kind of put it under the chief wellness officer. Should it be tied to risk management? A lot of the time, that's the first call people make when they have something really bad happen. So it's important to engage them as stakeholders. Obviously, is related to patient safety. HR can sometimes get involved, which can be not a good thing because HR involvement can feel very punitive. Thinking about who are your allies, a really unlikely ally that we had that I would never have thought was our pediatric psychologist. So when we presented at the fellow retreat, one of the psychologists presented with me. Obviously, they are trained and they practice taking care of children, but they are also trained to take care of adults, and they have a great skill set and we continue to work with them. But they were a really unlikely but powerful ally for me at the beginning. Gathering data, as I mentioned, just even that informal poll everywhere data was really powerful, because even though you might present data about like this exists in the literature, when you actually are able to show your local leaders, this exists here at Nemours and this is what our fellows are saying, I think that was powerful. And then once the program was kind of up and running, thinking about like, how do we actually get people to use it? How do we select peer supporters? How do we train them? How do we maintain their competency? So those are more kind of maintenance questions that I will get to. Our program is now comprehensive. It's up and running since about 2021. is for both clinical and non-clinical staff and trainees. We have a good amount of FTE support listed here. We have a steering committee with the members that I listed there. And it's available. There's a link on our website. There's a dedicated email. There's a dedicated phone number. We have a rule that we respond within 24 hours and we're available 24/7. There's a focus to really make sure we have enough people trained in units with high acuity or frequent stressors. And the hope is that the peer support is embedded. So even without initiating a formal referral, it's happening on these local units. And I'll talk a little bit more about this. We have a partnership with Quality and Safety to refer directly after a significant adverse event. So we don't have to rely on someone reporting. It happens automatically. So we published our experience over the first 3 years when we had 316 referrals. You can see the distribution here, largely nurses. Providers were the minority at 21%, and quite a bit of non-clinical, EVS, people who answer the phone lines, are also getting referred. We looked at the reasons for referral and the outcomes. So the most common reason people were getting referred was for an adverse event. And about 60% of people were supported. 30% had no response and 9% declined. And I will say even the people who decline or maybe who don't even respond, just the act of being offered support can have an impact on that person. Just the fact that you are being offered support can normalize the reaction that you're having. So it shouldn't feel like a failure just because you don't carry out the referral. There were significant differences between providers and non-providers when we broke down the data that way, which weren't surprising to me. The providers were much more likely to be referred for an adverse event or a patient outcome. And also the providers were less likely to self-refer. So neither of those things is too surprising. But they were actually more likely to complete the referral, which was I was a little bit surprised by. I wanted to say a word about Candor. This is a program that Nemours is actually now finally in the process of actually rolling out. We've been talking about it for like 10 years and we're now finally doing it. It's all about how your organization responds to an adverse event, and it's about transparency. And it is something that is a powerful kind of negotiating tool when you're talking to leadership, because this is something that people have bought into and that a lot of hospitals have done. And there's a whole kind of checklist and process that happens after an adverse event. And peer support is actually part of that. So right here, the event happens, you assess and inform, ensure the patient is stable, assess for harm, report the event to the professional responsible for patient safety events, and activate, they call it Care for the Caregiver program. So if you want to invest, if your hospital believes Candor is a good way to respond to adverse events, peer support is part of that. And this was really helpful for us in our early arguments, because Nemours has been contemplating doing Candor for a long time. But a peer support program is a required element. And then I mentioned before, when we first started the program, we didn't have any formal relationship with quality and safety. The quality and safety team, whenever there's any significant patient harm event, they conduct a series of interviews of any provider who was involved in the event or any clinician who was involved in the event. And it's possible that any of those individuals would benefit from peer support. So now whenever there's a significant harm event, when they are interviewed by patient safety, that automatically triggers a referral for peer support. And that's significantly increased our total referrals and also our completed referrals. So I think that was a really important change to the program. You can see here, the first year, 2020, we only had 15 referrals, and we've steadily grown for the most part each year. The purple are the patient safety referrals, so that really added a good chunk. And then we started peer support rounding. So if there was an unanticipated death on a unit or another significant event, peer supporters go kind of in a little group and they bring a wellness wagon and it has snacks. And it's just sort of an informal interaction with the unit. And then referrals can come for individual peer support out of those conversations as well. That's when we just started in the last couple of years and has also bulked the number of referrals. So we had an opportunity when we did our culture of safety survey. We do it through Gallup every 2 years. And we were able to add some questions about peer support into our Gallup survey and then test associations between peer support, burnout, and safety culture. I just wanted to share that with you. So this was our 2023 Culture of Safety survey, and we had about 3,500 responses across the enterprise. 23% of those individuals said that they were involved in a harm event or a patient experienced significant harm. And 60% of those said that they were experiencing significant emotional distress after the harm event. And then 48% of those who said they were experiencing distress said that they were offered support. So that was pretty good, getting to half of those people. We obviously have room for improvement. On the Gallup survey, there was a burnout, very simple burnout scale. This is if they were 3 through 5 definite burnout, the symptoms won't go away, or they feel completely burned out. We kind of dichotomize the data. If you were answered a 3, 4, or 5, you were considered burned out, and if not, for a 1 or a 2. And then we wanted to measure the impact of harm events on burnout. So the burnout rate of people who were had experienced a harm event was significantly higher than those who hadn't, 50% versus 30%. And if they reported that they were experiencing emotional distress after the harm event, their burnout rate was much higher, almost 70%, compared to 30% who, even though they experienced a harm event, they did not report emotional distress. So this is not surprising. We know that harm events contribute to burnout. But what we found was for those who said they were offered support, they were much less likely to be burned out. They brought their burnout rate down to about 63% versus 75% in those who were not offered support. And then similar impact on safety culture. So those who were offered support were more likely to rate higher safety culture scores, both in their local unit or work area and overall. So I think this was pretty compelling data, and this is not a novel finding. It's been shown before that having a peer support program can reduce burnout and can improve safety culture, but we were able to show that within our institution after starting our program. And then people worry about the impact on the peer supporters themselves. Is it emotionally taxing to provide support? And what we actually found was that 84% of the community of peer supporters felt that it gave them a sense of belonging to be part of the community. 90% said they felt more valued by the organization and that it increased professional and personal fulfillment. And 100% of the supporters said that the emotional and time demands were manageable. And I like this pie chart here because it shows, it's one thing to measure the impact through the formal referrals within the program, but I think probably more importantly, when we are training this population of people to be peer supporters, they're then using those skills outside of the formal program as well. So we said, how often are you using the skills? Daily, weekly, monthly, once or twice, pretty much the whole group said that they were using the skills outside of their formal referrals. So thinking beyond institutional peer support, because you always need a safety net. Not all organizations have a peer support program. Sometimes people prefer to be supported by someone who's not part of the organization. The American Society of Transplant Surgeons was really the pioneer here. They had a surgeon who experienced a death of a living donor liver transplant. The donor died, and she was the pioneer in building this program for ASTS, and we really followed their model for APSA. And we built an APSA peer support program. It can be accessed online. It's available to anyone. It's not behind a paywall or the membership only part of the site. It has a little intro video for me explaining what it is. This is Dr. Barksdale, who was the president when we launched it back in 2021. And then this is the referral form. So you have to fill in the name of the person being referred. The other fields are all optional. You don't need to, if you're referring someone else, you don't need to put your name. We have a whole bunch of reasons for referral. I don't know how well you guys can see this. When we started the program, it was really, we had limited it to adverse event or toxic work environment or other. We've kind of expanded the concept to say you could want to talk about, a divorce, a separation, a health problem, infertility, a job transition. So this isn't just about a significant traumatic event. It can be about any of these challenges that we experienced over the course of a career, and we have supporters who identify themselves as being willing to support others going through these challenges. We have retraining after a setback, we have retirement up here, we have substance abuse recovery. So you can also, not say the reason if you don't want to say the reason. So the referral goes in, an email goes really just to me, and to an administrator who helps with the program. And then I have our list of supporters and I help match someone based on the reason. And I try to match people based on kind of being similar career stages and backgrounds. Our experience in the first year of the program, we had 18 referrals and most of them were self-initiated. We were able to contact everyone within 24 hours. Most people wanted to talk about adverse events or a toxic work environment. And all of the referrals were completed and nobody refused support. And we've actually trained more people now, about 50 people. Now I think it's up to about 60. We just had another session in December. And we had surveyed the first group of people who were trained, and 94% of them felt prepared to provide support. And again, we asked the question about like, have you used the skills you learned in this training in other venues? And greater than 80% of them said they had. So I think again, in continuing to offer these trainings, we're just helping change culture in local environments, even if it's not through formal APSA program support encounters. All right, I just want to say a little bit about M&M, and I'm wrapping it up because I would like to have some time for questions. I mentioned M&M before. M&M came up in the open-ended survey that we did through APSA. It's the primary venue for adverse event review. I think it's the conference that almost every surgeon attends when you think about all the different adverse event review venues. Back when I was on the quality and safety committee for APSA, we did a survey. This was back in like 2015 or something. And most pediatric surgeons, about 85%, said that they always participate in M&M, but only 64% of them felt that it was effective in changing practice or preventing similar future adverse events. And the reasons people gave was that it didn't capture complications adequately, there was no structured approach, and there was no loop closure. I think there's another element to M&M. So I certainly grew up in a surgical M&M culture of shame and blame. I remember as a trainee, especially, it was really scary to have to get up there and present, and there was a lot of shame and blame. So this was a sort of a qualitative study, looking at M&M conferences and actually like recording observations live from the conferences. Everyone who cares about this job and really cares about what they do is going to take complications to heart. So that's the frame of reference going in. You're already feeling vulnerable if your case is being discussed. Someone said blood is in the water and the sharks would come at you and you knew you were going down and you would just take it. This feeling probably sounds familiar to many of you, especially who trained a few years back. At 12 out of the 15 observed M&M conferences, blame was assigned. Who was blamed? Residents, fellows, other medical surgical specialties, nursing, even the patient gets blamed sometimes. And it was coping addressed at only one of these 15 M&M conferences that were studied. One of the faculty members raised his hand. You're not a surgeon, you're an assassin, and her face crumbled. So this is disturbing, but not necessarily surprising data from this qualitative, or actually a mixed method study looking at surgical morbidity and mortality. So how do we move away from shame and blame? I think it's really about shifting the focus from the individual to the system and formally linking your M&Ms to quality improvement. And then also using your M&M as a platform to share QI updates from prior events. And I think when you turn it more into a quality improvement conference, it really shifts the focus of the conversation to the system and away from the individual. Individual failings, M&M is not the venue to discuss that. And it's really important for the moderator of the M&M to be able to kind of steer that conversation so that it's not about the individual and it's all about the system and what could we as the system have done to prevent something like this from happening again. So we at Nemours use a complications scoring system as part of our children's surgery verification. We kind of built an online M&M platform, and I don't have time to share too much more detail about that, except for the fact that every divisional M&M uses the system. Every M&M that is entered into the system is scored. into these levels. The level 1 is like a known complication. It was expected. We dealt with it appropriately. We tried to prevent it. We recognized it in a timely fashion, and we did everything right. So there's not really much improvement to come out of that. You kind of leave it there. Level 2, maybe it was unexpected, but we can't identify any opportunity for improvement. Similarly, usually not too many opportunities come out of that. But for the level 3s and 4s, if it was unexpected and potentially avoidable with the possibility to improve care, or was unexpected with a high likelihood to improve care, or something that would have been a level 1, but we didn't try to prevent it, or we didn't recognize it in a timely fashion. My message, so I'm the children's surgery program manager at our hospital, and my message to all of the division leaders of M&M is that if you score something as a level 3 or a level 4, I expect you to have, an action plan, and we have within our online system a place to write the action plan and then a place to assign who's responsible for loop closure. And when you check that box, it makes it come up in your M&M platform every week or every couple of weeks when you're doing M&M. So it keeps bringing the conversation back to these loop closure needed items. And I think requiring this QI link really helps shift the conversation to the system and away from the individual. And I think it's a really important way to kind of change that culture. So I like this quote just as we're sort of wrapping things up here. Complication is inevitable, it's part of being a surgeon, but suffering is optional. We don't have to suffer. And I think the way we support recovery is by creating a culture that normalizes the fact that it is hard and encourages conversation about it and shifts the focus away from the individual blame and towards system improvement. And we all feel better about a complication if we can fix the system so that that wouldn't happen again. So I think participating in this assessment and this quality improvement is actually another really important part of healing. And my message to you again is that each of you can play a critical role by always reaching out or making sure someone is reaching out to someone who is involved in an adverse event. And you can be a role model by initiating these conversations. And if you don't hear anything, you don't assume that things are okay. On the outside, everything seemed fine to me, for me, and I was really not fine because we're really good at putting up that front. And I want to wrap up with this video. Sorry, I forgot I wanted to do this real quick because this is Dr. Glaucom Flecken is a genius. And I think he has a video about a peer support encounter, and I think he nails it. So just give me one moment for this. Hopefully it'll work. Oh no. Okay.
Hello, President. Oh, hi, sir. Are you okay? Not really. I just had a surgical complication. I see. Was it? No. Anesthesia had nothing to do with it. It was all me. I don't know if I can do this job. Do you know the only way to avoid surgical complications? No. What? Stop operating. But I don't want to stop operating. Me neither, son. Me neither. It just really hurts to know that I hurt somebody. Good. That means you care. But does it ever stop hurting? For a while. Until it hits you again. Late at night, driving to work, 5, 10, 20 years later. Those patients never completely leave you. What do I do now? First you gather yourself, then you go see the patient and their family. You sit down. You be honest, empathetic, listen, then answer all the questions they have for as long as it takes. And you do that every single time you see them. How do I keep doing this? Well, you have two options. You can let this mistake define you and your ability as a surgeon, or you can use this as an opportunity to get better. Get better? Yes, make an effort to understand the factors that led to this and try as hard as you can never to let it happen again. Okay. And see a therapist. They can really help you with this kind of thing. You see a therapist? Of course, surgeons only use a few dozen neurons to operate. A therapist can help unlock the rest of it. That's a good idea. And keep your head up. You're a good surgeon. Thanks. Wait, how do you know? We've never worked together. Well, you're You're the president. There are lots of us. I'm sure you're great.
All right. Sorry, let me get rid of that and just finish up here. I love this image. So this is a Japanese art form called kintsugi, where you break a ceramic and then when you piece it back together, it's actually more beautiful and unique and interesting than it was before it broke. It's kind of a metaphor for all of this. So I'll leave on that note. And I'm happy to answer questions. I'm so sorry. I just saw the time and I'm like just right at the hour. So I don't know if we have time for questions, but thank you so much for having me today. It was really great having the opportunity to chat with you. And I know we have some time set up later for some of you to get to talk. So I don't know if there's any time for questions, but.
I think we can take a few. I have a few online. Dr. McGovern, one of our surgeons, asked, are there any legislative efforts anywhere that you know of to protect peer support from litigation concerns? And I have a quick answer to that because in Arizona in 2022, the House passed a bill protecting or allowing the Arizona Medical Association to have a confidential peer support program. And the hospital system Honor Health in the area has kind of used that to try and protect their peer support program. But Dr. Berman, I don't know if you know of anything
No,
more.
that's awesome to hear. I'm not aware of anything. So I'll add that to my my knowledge. But it's a great question. I tend to just like not focus on it. I think when you talk to lawyers, they can get very focused on it, but our in-house counsel has actually been very supportive of our litigation support program, which is specifically happening because of a lawsuit. So I think there's a way to kind of get past the conversation. And when you think about it, like I mean, I remember conversations I've had about peer support. I remember how distraught the clinician was, but I don't remember the details of the case. And so I wouldn't be too bothered. I think it would be very normal to say, yes, he was distraught. This terrible thing happened, but you're not going to share details that I think would help the plaintiff.
Another comment mentioned, thank you for your insights and honesty. Sometimes I worry the docs who are most in need of peer support, who have the most significant negative impact on the hospital community after an adverse event, are the least likely to have the insight to seek out and accept peer support. How do we deal with this? How do we ingrain this in our culture from day one of training or even in medical school?
That's a great question. I think very insightful. I think where I have found a way to get in on that, it's often like sort of older generation, tough, like, like, and I think we've had some surgeons at our hospital, some very senior surgeons have some very significant complications, and we've also been able to train some members of that generation. And I have been really astounded at how open they are to talking to someone they really feel like is a colleague about it. So I think it's really about defining and engaging a true peer. And then it doesn't have to even, you don't even have to call it peer support. It's just like a, wow, this thing happened to you. How are you doing? And not even like calling it that, but still having the conversation. Because you're right, some people are just going to block it out and be a wall and not want to talk about it. But if it's more kind of natural and ingrained in the culture, it just becomes normal.
And then lastly, would you please give an example of an action plan after M&M? Does it feel more like work trauma punishment for the involved team, or is the action plan work done by the M&M team or the division leader?
That's such a great point. So I think it really helps if you have like dedicated quality and safety team resources that can help carry out the action plans. It can absolutely feel very much like a punishment, like you had this terrible complication and now you're charged with fixing it and you don't have the time. So I think um, you know, the way it works at Nemours is when I'm reviewing all of these M&M output with action plans, I'm able to make sure that people are paired up with quality and safety team resources to help bring the action plans to fruition. I think a lot of it comes down to the M&M leader too. A lot of the time the action plan isn't the responsibility of the person whose complication it was. You know, for example, we had an M&M last week, I'll just give you. We had a trisomy 13 kid who got a G-tube, and we didn't want to put in the G-tube. It had been offered to the family, and we were afraid the kid wouldn't be able to be extubated, and the family just insisted on it. And we put it in the G-tube, and then the baby ended up not leaving the hospital because we could never get them off the ventilator. So the action plan was, why did the NICU even offer the option of a G tube in this case? It should never even be put on the table. This kid should have gone home with an NG tube. And I, as the surgical director of the NICU, took on that action plan of like, let's talk to the NICU and kind of get their side of the story. And I ended up organizing like a joint conference to talk about how we manage our trisomy 13, 18 babies and what's the role of palliative care and what do we offer them and not offer them. So in that sense, we didn't necessarily need to lean on the quality and safety team resources, but it was just something by writing it down. Like, you know how busy we are. We talk about it at M&M. We go back to our busy lives and nothing ever gets done. But because I was assigned to it and I knew it was coming up in 2 weeks, I actually carried it out. If it's more complex, like we had an orthopedic shoulder surgery mishap because we didn't have proper size retractors for this like adult sized patient, and we needed to actually get more equipment. So we used our quality and safety resource to like kind of link us with the proper OR management to get that. And so it doesn't fall on that orthopedic surgeon. But I think it's a really important point. You don't want it to turn into like homework and more kind of emotional distress related to that responsibility. And you want to really be able to support people in carrying out those action plans.
Well, thank you again. I think the data speaks for itself, and you've done a great job at your local institution and also nationally with that. And in about 10 minutes, we'll be meeting with several stakeholders identified at Phoenix Children's to have a further small group conversation with you about exploring a peer support program at this institution. So thank you again. And there were several comments appreciating the work that you've done as well.
Thank you so much. Put my contact info in the slides. If anyone has follow-up questions or wants to kind of talk more about it, I'd be happy to email me and look forward to chatting with some of you in a few minutes. But thank you